my job is to introduce a man I don't know how to describe. That's the tough. How do you describe a man? When I ask different people to describe Dr. Smalling, what is the first thing that comes to your mind? A great clinician, a top doctor, a great technician, a rocket scientist, a legend, an author, a scientist. So how do I try to introduce that person? He's truly one person who's a legend in field of, and a giant in the field of cardiovascular medicine, and he has shouldered this responsibility so admirably for over so many years and continues to do so. I think he works harder than any one of us, even now. I don't know what motivates him, but he is a biomedical engineer. He's a true rocket scientist. He's an aerospace engineer also and a PhD. And he's an interventional cardiologist par excellence. He has authored more articles than all of us combined in the medical center. He has written more book chapters than all of us combined in the medical chapter. Yet he has time to pioneer heart failure therapies. He has multiple patents in his name, and his Windmill Associates is your company, which is making the first valveless LVAD, which is completely implantable. I was so impressed. He took me to his room and showed a video that this is a pump which flows 5 to 6 liters, and a live fish went through the pump and came out alive on the other side. So I did not know, in all those adjectives I used, he's also a magician. So it's my complete honor and a privilege to introduce a man who we have all tried to emulate, and his footsteps leads the way for all of us to be in this interventional cardiology field. Dr. Smalling, my honor to introduce him.
I wish my mother were still alive to have heard that, but she wouldn't believe it. So, Biswaji, thank you for asking me, Marwan. I've never been asked to give a keynote address, and I think that means I'm old. So I've ascended. These are my disclosures. I'm going to start in a much different tack. This will be the first time I've ever given this talk, and it's going to be a little different. In 1979, I was at UC San Diego, and we had a patient in the VA that had an acute anterior MI. And then you gave morphine and maybe some heparin and some lidocaine for sure, and that was about it. And the guy had ongoing pain and was sent for bypass surgery and had a lima to his LAD. He had a critical LAD lesion but was not occluded. His anterior wall was completely akinetic, and after surgery, his T waves across the anterior precordium all flipped, and the STs came down, and it looked ischemic. We didn't know then that was actually a good sign that reperfusion injury had been prevented. So, we worried about him, brought him back in about a month, and re-angioed him. His graft was patent, his LV function was normal. And so I went to Dr. John Ross Jr. and said, I want to explore this. Why do these things happen? And we wrote a grant that gave me a clinical investigator award from the NIH, and ultimately I was recruited to Houston to come back home, and that started a journey. That was a long time ago. When I was researching the articles to base some of this talk on, I realized a good portion of the people that I remembered and contributed to this were all dead. So it keeps you focused. You say, well, what's the next step? I think we absolutely have to focus on how do we design trials. So part of this talk is going to be about asking the questions. Is there a way to get this in a larger format, or is it presenter way? Yeah, there actually is, but at any rate, so timing is important. You have to know how soon after the patient had ischemia and what intervention you're going to do. You have to know what are the mechanisms of acute ischemic myocardial necrosis and what's the time frame from duration of ischemia to presence of reperfusion, and how does that impact the outcome? How can you measure myocardial salvage? Can myocardial salvage still occur if a protective intervention is initiated relatively late in the course after the onset of ischemia? What are the mechanisms of delayed ischemic salvage? and how can you measure delayed myocardial salvage or reduced late myocardial infarction. So you got to measure it. There's two phases. This was really brought home by a series of papers looking at cardiac MRI. And cardiac MRI, if you use the T2 weighted images, you get even 3 to 5 days post-MI, you get the region at risk. And then if you give gadolinium and do a delayed image, you get the actual infarct size. And unfortunately, I don't have a pointer or a way to maneuver that. But if you focus on the far left side of these images, these are patients who presented within 90 minutes of onset of symptoms, and they all had primary PCI. The region at risk in the A row, and this patient on the top was an inferior MI, and you see a white area. That's the region at risk. And if you drop down, there's a little narrow subendocardial white layer, which is the delayed image, and that's actual infarct. So the tissue that's actually infarcted over the region at risk is the inverse of infarct salvage. And so the same thing applies for anterior MIs. The B column below that shows very spotty infarction. So this defined that if you're going to do an intervention to salvage myocardium, basically you have to do it within 120 minutes. So if you're going to do an intervention, which really works well in animals, you have to have a patient presenting in the first 120 minutes and give the intervention, do the intervention prior to reperfusion if you're going to hope to show salvage. So that's really important. There's a lot of things that work, but when you design the trial, and I'm guilty of this as well, you don't know, at least at the time we designed one of the trials, that this was important. So this is due to calcium overload. We initially thought that we knew unloading seemed to work. Buckberg and Allen back in the late 70s, early 80s published a paper in dogs where they did cardiopulmonary bypass on dogs that were infarcting, and showed that if you unloaded the dog before you did the bypass graft and reperfused, you would achieve significant salvage. And so the unloading thing really started in Buckberg's lab. We thought that the unloading probably reduced activation of adhesion molecules, and because at the time the dogma was this infarction is caused by white cells coming in and eating the myocytes, basically. So we hypothesized that if we could reduce wall stress, then we could reduce the ischemic injury due to these activated adhesion molecules. So I spent 4 years learning all about adhesion molecules and stuff like that. And we put in sonar micrometer crystals in this case, these were dogs, and showed that the wall actually thickened abruptly on reperfusion if you didn't protect the heart. And that actually lowered the wall stress, so we had a negative trial. We had lower wall stress but no salvage. And when we looked at it, and Dr. Bouye, sitting up here, did the electron microscopy, it's due to calcium overload and contraction band necrosis. So if you don't unload prior to reperfusion in acute ischemia, and it's in the early phase, you end up with contraction band necrosis and this early infarct due to calcium overload. And if you unload prior to reperfusion, that does not occur. So the first mechanism that appeared evident to us, it wasn't the white blood cells, it was calcium overload. The next thing that happened was the timing. So this was, again, the paper that we published on early unloading, and this was an LVAD that was basically a hemopump, a different type of hemopump, which would be an Impella 5 if you use Impella terminology. And if you unloaded before you reperfused, you had a dramatic infarct salvage. We then looked in rabbits and sheep and pigs, and all found the same thing. And basically we started looking at calcium in the tissue. On the left side, in the control group, you can see that actually in the unloaded group, the calcium did not increase in the tissue on reperfusion, but in the control group that did. So, and similarly, if you look at apoptosis, Apoptosis occurred in patients that, or in dogs that weren't unloaded and then were reperfused, or in dogs that were reperfused after, were unloaded after reperfusion. So apoptosis is a slower process. So we think that apoptosis accounts for the late decline that you see in the next 6 months to a year after the acute ischemic event. All the data, whether it's thrombolytic data, whether it's dog data, whether it's MRI data, shows this salvage decline in the first 2 hours. And then beyond 2 hours, you really can't show benefit. And even though you have an intervention which might be helpful, if you do it too late, you won't be able to show benefit and you'll have a negative trial. So these are all the thrombolytic trials. All of them were done way too late to show benefit. Now, we found that liposomal prostaglandin E1 inhibits white blood cell activation, and it also reduces infarct size, and that's one of the rabbit holes we went down for a while. We found that the control animals that got intracoronary heparin, when we were looking at supersaturated oxygenated blood to protect the myocardium, the control animals got benefit that supersaturated animals didn't, and it all related to endothelin. It turns out that one of our researchers was a cardiologist from Tunisia, and she came to the United States because her husband was transferred here, and she looked at all the things that we had done and said, everything goes back to endothelin. Everything that we did inhibits endothelin release. So then we looked at coronary sinus endothelin subtracted from aortic endothelin and found this big bump in endothelin in animals that were unloaded without protection. And then we unloaded the animals and the endothelin didn't go up, okay? And so, let's see. This was endothelin inhibition on intracellular and myocyte viability in isolated rabbit myocytes. So this was done in Utah by Dr. Berry and his associates, and they actually took myocytes, cultured myocytes, did simulated ischemia by hypoxia in the supernate, and you can see the calcium influx into these myocytes. And then they gave endothelin in addition to the calcium, and it went up further. Then they gave an endothelin antagonist, and it was blocked. And so this, and also the similar results for cell salvage on the right there. And this mirrored what we had predicted. So in cultured cells, the same thing was happening that we were seeing in the intact myocardium. These data most people have never seen, but it has continued for the last 20 years. We figured out a way to put an LVAD in a rabbit, and that's a whole other story. But we did a series of experiments where we either unloaded rabbits or didn't unload rabbits, and we reperfused unloaded prior or after reperfusion. And what we found was if you give an endothelin antagonist prior to reperfusion, you get significant protection. If you unload prior to reperfusion, you get significant protection. If you do both, there's no difference. It's not an additive effect. So what that told us was endothelin is a good target. So endothelin antagonists were developed for pulmonary hypertension, as you well know. Some of them cause liver toxicity. The big companies all had one running, and it became very difficult to get people interested in looking at the possibility of using an endothelin antagonist to reduce infarct size. We did find some support. We had a typical animal model. We used amricitin, and this was in a pig model. It did drop the blood pressure a little bit. I'm going to go ahead fairly quickly. What you can see here, the region at risk is bright red, the control region is blue, and the infarcted tissue is tan. And these are fairly large infarcts. It was in an LED infarction model in a pig. And then when we gave ambrisentan prior to reperfusion, there was just a dot. So dramatic result. However, the blood pressure dropped a little bit. And you can also see endothelin activity was eliminated by the ambrisentan. It did drop the blood pressure a little bit. It did significantly reduce infarct size. But if you looked at collateral blood flow, it had absolutely no effect on collateral blood flow in the risk region, and still there was tremendous salvage. So it was not flow dependent. It wasn't a vasodilator effect. It was a direct effect on calcium flux and apoptosis. And basically, apoptosis was reduced in addition to the calcium overload damage. And the infarct salvage was dependent on timing of administration of the agent. I'm going to flip through this. Let's go back one. So we had LVADs, but we couldn't put in an LVAD. We didn't have an endothelin antagonist, so we looked at the balloon pump. So in large pigs, 70-kilogram pigs, we did a series of animals where we unloaded prior to reperfusion with a balloon pump, or after reperfusion with a balloon pump, or didn't unload at all, and found exactly the same results as we found with an Impella-like, big Impella-like device. And so that led to, this also showed the decrease in endothelin release. That led to a clinical trial. So this was CRISP-AMI. It was targeted in patients with large anterior infarcts without shock. The hypothesis was that if you got somebody with a large anterior MI, put a balloon pump in just prior to primary PCI, it would produce salvage similar to what we saw in the animal lab. This was at the time when the MRI results were just being published and there wasn't a timing issue in the initial MRI results. So we didn't know that you had to do the unloading way before 2 hours or before 3 hours. And unfortunately, most of the patients came in at 3 to 4 hours after onset of symptoms. So you're not going to see a calcium overload benefit. You're not going to see an infarct size benefit, which is how we designed the trial. So we screwed up. We didn't know that. It was a negative trial. On the other hand, when we looked for up to 6 months, what we found was something a little different. This is the primary outcome, no difference in acute infarct size. Negative trial, balloon pumps don't work, okay? If we looked at the infarct salvage in patients presenting very early, there was tremendous infarct salvage. But the vast majority, the red bars show the vast majority of patients came in very late. And so there wasn't this infarct size advantage. Fortunately, we designed into the trial an extended follow-up period. And what we found was that the mortality rate, if you got unloaded prior to reperfusion, was very low and significantly lower than if you didn't. But the trial was underpowered to detect this mortality advantage. If you look at a surrogate, which is delayed mortality, heart failure, or shock, up to 6 months, there was about a 70% reduction in that endpoint. Highly significant. And this, I think, speaks to the fact that what we achieved was this inhibition of apoptosis with the delayed unloading. And the effect was really not, it was across all time frames. So even if you unloaded prior to reperfusion in these humans, you got a positive effect, even up to 6 or 8 hours. So that tells us that if somebody comes in late, you can still unload prior to reperfusion and you should get an improved survival. And Bill O'Neill and his colleagues showed this in unrandomized data, basically unloading prior to reperfusion. If they come late, you're going to have a late mortality advantage. So as one that goes forward designing trials, if you're going to do something you want a big bang with, you have to do it very early. I think the take-homes for me is that you really need to do LV unloading early. We showed that you could have some benefit late, and the myocardial necrosis and heart failure can be prevented with later unloading. So to put this in clinical perspective, it would be nice if we had an endothelin antagonist that we could give pre-hospital. We're working on that. If you gave a pre-hospital endothelin antagonist and then gave them a pre-hospital lytic half dose, we've shown that there's no bleeding penalty, and there's probably a 70% reduction in mortality with the pre-hospital lytics. Then you could have a 1-2 punch, and somebody would come in with an acute MI and go home with a normal heart. That's the goal. If you have primary PCI, you got a big anterior infarct, I'd put a balloon pump, even if they're stable, I'd put a balloon pump in before you pop the LAD. And these results all could potentially be drastically improved if you gave an early endothelin antagonist. So thank you very much. It's been an honor to have the opportunity to visit. I'm happy to take some questions.
That was a great talk and a tremendous history. And again, congrats. While the audience is coming up, you made the point that whether or not you provided a mechanical approach or you used the endothelian antagonist, you didn't see a synergistic effect.
Correct.
What are your thoughts? I mean,
I think to speak to the mechanism, the enloading appears to inhibit endothelin release, and if you already blocked the endothelin, it's not going to have an effect.
that's universal, or is that just in that particular group? I mean, my point is that
we've seen it in every animal species we looked at, independent of collateral blood flow. So we've seen it in rabbits, pigs, sheep, dogs.
my question is more about in humans with atherosclerotic disease. Some of them have significant endothelial dysfunction.
Yeah.
And in that group, you may not be able to see that response. What are your thoughts?
I'm not sure. I'm not sure. I mean, we showed, at least in CRISP AMI, that unloading did appear to have late salvage, and that goes along with the inhibition of apoptosis. And so if that's the case, you would expect that it did have an effect on the endothelium. Yeah.
Take a mic. Can we have a mic?
Mic for Dr. Bouya.
Stereo.
I admire your tenacity, and I think you should be congratulated for that. It's no fun to have a negative trial or a negative set of experiments, but you've persisted. But one question is, so this endothelial release is ischemic endothelial cells in the bed at risk? What's the source of the endothelium?
We think it's the ischemic endothelial cells in the bed at risk, yeah.
And they also release nitric oxide, presumably?
We didn't measure nitric oxide.
But that comes and goes, whereas endothelium persists.
Yeah.
So what you're really doing is affecting remodeling in the viable myocardium that survived the infarct initially. Is that?
No, I think because there's two things that get triggered. In our experience, two things we've observed is calcium overload acutely,
right,
and apoptosis late, and endothelial antagonists inhibit both, as does unloading, and the apoptosis continues, I think, after the acute ischemic insult for a period of time. I don't know what that is.
Yeah, but where? The infarct is done, and you must be affecting the border zone.
Border zone, most likely.
Right. But is it happening just within that bed at risk? Or more globally?
We don't know that.
You don't know that, yeah. Right. It's a fascinating observation.
Yeah. Mm-hmm. I think Dr. Rami has Eddie?
Eddie, while you're asking that, do you think it has to be local, or do you think you can give it systemically? Are you going to achieve the doses
Systemically.
I know, but do you think it would be better locally?
No, I think systemic would be
Okay.
best, because you could do it pre-hospital.
Eddie?
Yeah, so I have a
Oh,
question.
you have, go ahead. I can't see with the lights, sorry.
Oh, that's okay. So in terms of acute MI, we see these patients who get unloading devices, impeller or balloon pump. So I just feel like some of these devices don't work because these patients have diastolic dysfunction. So we have a lot of trouble with impeller just having low flows because they have significant diastolic dysfunction. So do you think there are mechanisms to improve diastolic dysfunction? Because I just don't think unloading with mechanical pumps in some of these patients with AMI works. So
Yeah, so in CRISP, we studied people that were hemodynamically fine. So we can't answer that, I don't think, at this time.
That was a phenomenal presentation summarizing a tremendous amount of work. Just a couple questions about some of the endothelium issues. Did I see that we're talking about 10 milligrams per kilogram of ambrisentan? Isn't that like an order of magnitude higher than the actual human dose?
We actually did a dose ranging trial, and that's what popped out as something that was about 3 times as large as what we found the minimally effective dose was.
Because isn't the dose like 10 milligrams
I-
total in humans? Something like
I can, yeah.
Okay. Because you mentioned the hypotension, and obviously if you're using a high dose, I'd worry. And the other question was, is it dependent on the A or B receptor?
It's
both?
A. It's A.
Okay, so there's the more specific ones.
Yeah.
And then, there's quite a bit of data looking at endothelin receptor antagonists in heart failure, and is there any concern that the heart failure signal fluid retention could potentially be a problem if you use
This is a one-shot pre-reperfusion. That's it.
Thank you.
Yeah.
Just a thought, it might be nice in the trial, a little subset if you could do it. There are a lot of quick ways to, from the days of the old cold pressor test to looking at capillary refill to get a quick sense of endothelial function, because that may be, the heterogeneity may undermine what would otherwise be a great result.
So the pig model, they're very sensitive to the endothelial antagonist blood pressure-wise. We've switched to a sheep model. We're doing the sheep experiments. A different endothelial antagonist doesn't seem to drop the pressure that much. So we'll see. It's going to be a long haul to get somebody interested in this.
Right.
Eddie?
I want to just say this is the first time I hear you speak on non-pump biology, and it's a pleasure, Richard. I had no idea you were doing this work. I've heard about this work. I didn't know it was you. I have 2 questions. pH trials, there's many. They don't have a secondary surrogate endpoint of adverse events, but the early ones in Europe do. Do you think it could be worthwhile looking at, I don't know, any protective effects of patients with pH that had MIs? I mean, there's not going to be many patients.
Yeah.
So, and the reason I ask is because you're looking at this as a one-shot deal. I actually think it's a great comment that he made. In heart failure, the folks from the VA San Francisco, UCSF VA, John, I've forgotten his last name, Tierlink. John did the trials in patients with a whole broad spectrum of heart failure, and they were negative, and there was some harm. But I want you to know, I think this is incredible if you're able to test this in humans with Gilead. But
Gilead's out.
Okay. So now my second question, my final question is: do you believe that if the dose could be tolerated in terms of the safety, do you think there's any role for ongoing injury more beyond into the border zone if humans can, let's say hypertensive humans can tolerate it?
Yeah, I don't know, Eddie. First we've got to get somebody interested, and that's been a challenge. Yeah.
Dr. Smalling, I have 2 questions. Looks like we have a surrogate marker for unloading, which is basically delayed apoptosis. So is there a role of comparing impella, tandem, ECMO, and seeing if the...
So with the idea of extent of unloading, so in the animals, it didn't seem to matter whether you used a balloon pump, whether you used impella, or what we had at the time was an AMED device. The degree of unloading doesn't seem to be that important. A little bit of unloading seems to go a long way for this particular issue.
Anybody measure caspases in the blood?
No.
That might be a way to non-invasively track apoptosis.
So send me an email. how to do it, yeah.
Yeah, or an exon, you could do an exon. I mean, there are a couple different biomarkers that you could do. An exon 5 binding, caspase. If you did, the issue with the trial is you'd have to do a biopsy other than doing these blood markers. Yeah, because you'd see, nuclear segmentation. I mean, there are a lot of. Okay, yeah, there you go.
I have one comment. Coming from the pulmonary world again, I think endothelin, and then I think it may be a good time because Letairis is going generic, so maybe it won't be a bad idea to give it an IV. But we give 10 milligrams per day, so this is like an astronomical dose. The second thing is with Adempus, the riociguat with the activated guanylyl cyclase activator, if the end result of your endothelin receptor antagonism is helping this, do you think that there is a role for the newer PAH medications as well?
I don't know. I don't know. We sort of, I have to slip away and when people are not aware to do this stuff, so I don't have a lot of time for it. But if you're interested, we'll let you join in.